I want to talk to you today about something that has been sitting in the medical literature for over 20 years. Something that your cardiologist knows exists. Something that the pharmaceutical companies acknowledge in the fine print of their own prescribing information. And something that is almost never mentioned in the appointment where your statin is prescribed, renewed, or increased. If you are taking a statin right now, I want you to stay with me through this entire video. Not because I am going to tell you to stop it. I am not. Statins save lives, and if yours was prescribed for the right reasons, it may be doing something genuinely important for your heart, but saving your heart while quietly taking something else from you. Something you have probably blamed on aging, on poor sleep, on not exercising enough, is not acceptable. And it is happening to millions of people who deserve to know about it. Here is what I want you to picture. Think about how you felt physically 5 years ago, not your cardiovascular numbers, your physical self, how easily you carried groceries, how your legs felt climbing stairs, how quickly you recovered after a long walk, how your grip felt when you opened a jar. Now compare that to today. If there has been a change, and for many of you watching there has, I want you to consider a question that almost nobody has asked you. When did you start your statin? I am Dr. Amelia Carter. I have spent 20 years in cardiovascular medicine, and my mission is not to frighten you about your medication. My mission is to make sure you have the complete picture. The part of the conversation that gets left out because there is not enough time, or because the benefit is real and the side effect is invisible, or because by the time the connection becomes obvious, it has already been happening for years. By the end of this video, you are going to understand exactly what statins do to a molecule your muscles cannot survive without. You are going to know the symptoms that tell you whether this is happening to you. You are going to know the test that confirms it. And you are going to have the exact words to bring to your next appointment. Not to stop your medication, but to protect yourself while you take it. Before I show you the mechanism, I want to tell you about a patient. Because the mechanism alone will not make this real, but his story will. And after I tell you his story, I need you to think about whether any part of it sounds familiar. His name was Bernard. Bernard was 64 years old when he first came to see me. He had been on atorvastatin for 6 years. His LDL was excellent. His cardiologist was pleased. His annual blood work was consistently reassuring. But Bernard had a complaint. And the reason he brought it to me instead of his cardiologist is that he did not think it was related to his heart. He was tired, not the kind of tired that sleep fixes, the kind of tired that is there when you wake up, that sits in your legs and your arms and your chest like a low-level weight that you have learned to carry but can never quite put down. He had reduced his walking from 3 miles to 1. He told himself it was the weather. Then it was his knee. Then it was just that he was 64, and this was what 64 felt like. His wife had noticed something else. Bernard's handshake, she told me, had changed. He had always had a firm handshake, the kind of handshake you remember. In the past 2 years, it had become softer. She had not told him. She had not wanted to worry him. Bernard also mentioned, almost as an aside, that he had been having leg cramps at night, mostly in his calves. He had been drinking more water, as his GP had suggested. The cramps continued. I looked at Bernard's medication list. I looked at the timeline. And then I asked him a question that nobody had asked him in 6 years of statin therapy. I asked him, "Has anyone ever tested your CoQ10 level?" He looked at me the way people look when they are not sure what the question means. Nobody had. CoQ10, coenzyme Q10. It sounds like a supplement. It sounds optional. It sounds like something you see next to the fish oil in the pharmacy aisle. It is none of those things. It is the molecule your mitochondria use to produce energy. Every cell in your body, every heartbeat, every muscle contraction, every moment of physical effort your body makes. Without adequate CoQ10, your muscle cells cannot produce energy efficiently, and statins by design reduce CoQ10 production. Every statin, in every patient, as part of the mechanism by which they work. This is what your cardiologist will almost never mention, not because they are careless, not because they are withholding something, But because the conversation about cardiovascular protection in a 12-minute appointment does not leave room for the conversation about what protecting the heart might be doing to the rest of you, this video is that conversation. Before I show you the mechanism, I want to ask you something, and I want you to answer it honestly for yourself. Since starting your statin, have you noticed any of the following? Muscle fatigue or weakness that is out of proportion to your activity level, a tiredness that does not improve reliably with sleep, leg cramps, especially at night, that have not responded to staying better hydrated, a reduction in your exercise tolerance, things that used to feel easy now feeling difficult, muscle soreness that lingers longer than it used to after ordinary activity. If you answered yes to even one of those, I am not going to tell you that your statin is definitely the cause. I am going to tell you that you deserve an investigation. And by the end of this video, you will know exactly what that investigation looks like. There are 3 types of people watching this right now. The first type is on a statin, has noticed changes in strength and energy, and has accepted them as aging. You are the most important person watching. What I am about to show you may explain something that has been building for years. The second type is on a statin and feels completely fine. Stay, because CoQ10 depletion is gradual and often invisible until it has been accumulating for a long time. Understanding this now, before symptoms develop, is exactly the kind of prevention this channel exists for. The third type is not on a statin but has a parent, a spouse, or someone they love who is. You will leave this video with a question worth asking at their next appointment. Let me show you exactly what is happening. Statins work by inhibiting an enzyme called HMG-CoA reductase. This enzyme controls a critical step in the mevalonate pathway, the biochemical route your liver uses to produce cholesterol. Block that enzyme and LDL cholesterol falls. The cardiovascular protection is real, and in patients with established heart disease or significant risk factors, it is meaningful. But here is what the mevalonate pathway also produces. Alongside cholesterol, it produces a compound called mevalonate, which goes on to produce several other molecules. One of those molecules is called farnesyl pyrophosphate, and farnesyl pyrophosphate is a direct precursor to CoQ10. When a statin blocks HMG-CoA reductase, it does not selectively block the cholesterol branch of the pathway while leaving the CoQ10 branch untouched. It reduces the production of the entire pathway. Cholesterol falls, and CoQ10 production falls with it. This is not a side effect in the traditional sense. It is a pharmacological consequence of exactly how the drug works. It is in the mechanism. It is documented in the prescribing information, and it is almost never discussed with patients. Now I want to show you what CoQ10 actually does, because most people who have heard of it think of it as a supplement. What it actually is infrastructure. Inside every cell in your body are structures called mitochondria. The mitochondria are your cellular power stations. They take the fuel you consume, glucose, fatty acids, and convert it into a usable form of energy called ATP, adenosine triphosphate. ATP is the currency of cellular energy. Every muscle contraction, every nerve impulse, every biological process that requires energy uses ATP. CoQ10 sits at the center of the mitochondrial energy production chain. Specifically, it acts as an electron carrier, a shuttle that moves electrons between the protein complexes that generate ATP. Without CoQ10 in adequate quantities, this chain slows. The mitochondria cannot produce ATP efficiently. The cell runs short of energy. Think of it this way: your mitochondria are a factory producing energy all day long. CoQ10 is the conveyor belt that keeps the production line moving. Reduce the conveyor belt, and the factory does not stop, but it produces less, and the cells that need the most energy, your heart muscle, your skeletal muscles, your brain, are the first to feel the shortage. Muscle cells are among the highest energy consumers in the body. They are running their mitochondria at high capacity every time you move. When CoQ10 is depleted, those mitochondria cannot sustain that output. The muscle cells produce less ATP per unit of effort. You feel this as fatigue that is disproportionate to what you are doing, as weakness that is not explained by inactivity, as a body that is working harder than it should for the same results. The muscle cells most affected are the slow twitch fibers, the ones responsible for endurance and sustained activity, not explosive power. This is why statin-related muscle effects tend to show up as a gradual reduction in stamina rather than sudden acute pain. They do not arrive dramatically. They arrive quietly, over months, accumulating in a way that is easy to attribute to getting older. Because the symptoms of CoQ10 depletion and the symptoms of normal aging look almost identical. Fatigue, reduced exercise tolerance, muscle weakness, slower recovery, the only way to tell them apart is to test. The clinical reality here is the number that I want you to write down. In a 2014 meta-analysis published in the Journal of the American College of Cardiology, researchers found that statin users had CoQ10 blood levels that were, on average, 40% lower than non-users. 40% lower. That is not a marginal reduction. That is a substantive depletion of the molecule your muscles use to produce energy, occurring in patients who are otherwise being told their blood work looks excellent. And in the same analysis, patients who supplemented CoQ10 showed significant improvement in muscle pain, fatigue, and functional capacity compared to those who did not. I also want to tell you something about the heart specifically, because if you are on a statin, your cardiologist is watching your heart closely. The heart is the highest energy organ in the human body. It beats 100,000 times a day. It never rests. It is almost entirely dependent on mitochondrial ATP production, and it is packed with CoQ10, more CoQ10 per gram of tissue than almost any other organ in the body. The concentration of CoQ10 in cardiac tissue actually declines naturally with age. In adults over 60, cardiac CoQ10 levels are already lower than they were at 40. Add a statin on top of that natural decline, and the cardiac mitochondria are running a depleted energy production system in the organ that can least afford it. I am not telling you that statins cause heart failure. The evidence does not support that in the broader population, and I would not suggest otherwise. What I am telling you is that the conversation about cardiac energy metabolism and what your statin is doing to the molecule that fuels it has never been part of your appointment. And after today, you will know to ask. I said Bernard's story would become clear by the end of this video. We are getting close to that point. But before I give you the protocol and the doctor dialogue, I need to show you the symptom map. Because different patterns of CoQ10 depletion manifest differently in different people, and knowing which pattern is yours tells you what to ask for and what to prioritize. CoQ10 depletion from statins can show up in 3 distinct patterns. Most people have elements of more than one, but I want you to identify which is your primary experience because it changes the priority of the response. Pattern 1. Muscle fatigue and reduced exercise tolerance. This is the most common pattern. The muscle cells are producing less ATP per unit of effort. You can still exercise, but the effort feels greater and the recovery is slower. Things that used to feel like a normal exertion now feel like a significant one. This pattern often develops gradually over the first 1 to 3 years of statin therapy, which is exactly why it is so easily attributed to normal aging. The trajectory, not the symptom itself, is the signal. If your exercise tolerance has been declining at a rate that is faster than your age alone should account for, this pattern warrants investigation. The self-check. Think about a specific physical task you perform regularly: carrying groceries, climbing your stairs, walking to the car. Has the effort required for that specific task increased over the past 1 to 2 years? Not because of a specific injury or illness, just gradually, without an obvious cause? That gradient is the data point. Pattern 2. Nocturnal muscle cramps. Nighttime leg cramps in statin users are a well-documented manifestation of CoQ10 depletion, compounded in many cases by the electrolyte effects of concurrent diuretic therapy. The muscle cell that cannot produce adequate ATP also cannot maintain the electrochemical gradients across its membrane that prevent involuntary contraction. The cramp is not the cause, it is the signal. And telling a patient with statin-related leg cramps to drink more water, while appropriate as supportive advice, does not address the mechanism driving the cramp. If you are on a statin and experiencing regular nocturnal leg cramps that have not resolved with hydration and basic electrolyte attention, CoQ10 depletion is on the differential diagnosis. Not the only explanation, but one that is clinically supported and directly testable. Pattern 3. Generalized fatigue, disproportionate to activity. This is Bernard's pattern. A deep, cellular fatigue that does not correlate clearly with how much you have done. You can have a restful day and still feel tired. You sleep adequately and wake up not fully restored. The fatigue is not dramatic, it is baseline, a persistent low-level depletion that you have learned to work around. This pattern is the hardest to attribute to any single cause because it resembles the fatigue of so many other conditions: anemia, hypothyroidism, depression, sleep apnea, B12 deficiency. This is why the investigation matters, not to confirm CoQ10 depletion as the cause, but to ensure it has been ruled in or out before other diagnoses are pursued or before the fatigue is attributed entirely to age. One more thing before the protocol: statin-related muscle effects exist on a spectrum. At the mild end is the fatigue and reduced tolerance I have been describing. At the more significant end is a condition called statin-associated myopathy, documented muscle damage reflected in elevated creatine kinase levels in the blood. And at the serious end, rarely, is a condition called rhabdomyolysis, in which muscle tissue breaks down rapidly and releases proteins that can damage the kidneys. I am not raising rhabdomyolysis to frighten you. It is rare and it is not what most of the people watching this are experiencing. I am raising it because the spectrum matters, because understanding that fatigue and cramps are the early signal of a spectrum that warrants attention is the argument for investigating now rather than attributing it to age and continuing. The earlier you identify where you sit on that spectrum, the more options are available. Now I want to show you exactly what to do: the test, the supplement protocol, and the conversation with your prescriber that protects your muscles without asking you to choose between your heart and your strength. Because you should not have to choose. Step 1 is the test. And I want to give you the specific names so you can request them without ambiguity. Creatine kinase, CK. This is the primary blood test for statin-associated muscle damage. CK is an enzyme that leaks from damaged muscle cells into the bloodstream. In statin myopathy, CK is elevated above the normal range. In rhabdomyolysis, it can be dramatically elevated. A baseline CK level, measured before a statin is started, is the reference point against which any subsequent elevation is interpreted. Many patients on statins have never had their CK measured at all. If you have not, that is the first conversation to have. CoQ10 blood level. This test is not part of a standard panel. It must be specifically requested. It measures the circulating CoQ10 level in the blood, which reflects the systemic availability of the molecule. It is not available at every laboratory, but it is increasingly accessible. If your practice cannot order it directly, a referral to a metabolic specialist or a private laboratory can provide it. Request it by name. Comprehensive Metabolic Panel. To confirm kidney and liver function as a baseline before starting any supplementation protocol. Step 2 is the supplement. And I want to be specific about form, dose, and timing because these details determine whether it works. CoQ10 is available in two main forms: ubiquinone and ubiquinol. Ubiquinone is the oxidized form, the form found in most standard supplements. To be used by the mitochondria, ubiquinone must be converted to ubiquinol inside the cell. In younger adults, this conversion is efficient. In adults over 60, the conversion capacity declines. Ubiquinol is the reduced active form that the mitochondria can use directly. It does not require conversion. In adults over 60, ubiquinol is the preferred form. If the bottle in your hand says CoQ10 and does not specify which form, it is almost certainly ubiquinone. Dose: 100 to 200 milligrams of ubiquinol daily. For patients on higher statin doses, 40 or 80 milligrams of atorvastatin or rosuvastatin, some clinicians use 200 to 300 milligrams. This is a conversation to have with your prescriber before exceeding 200 milligrams. Timing: CoQ10 is fat-soluble. It requires dietary fat to absorb. Take it with your largest meal of the day, the meal most likely to contain some fat. Do not take it with water alone. Do not take it on an empty stomach. Timeline: CoQ10. Supplementation is not a rapid intervention. Clinical studies that show meaningful benefit in statin-related muscle symptoms typically run for 8 to 12 weeks. Do not judge the result after 2 weeks. Give it a full 12-week trial with consistent daily dosing before assessing whether it has made a difference. There is one additional intervention I want to mention because it is often overlooked in the CoQ10 conversation. If you are on a statin and you are also on a loop diuretic, furosemide for example, your magnesium and potassium are being depleted alongside whatever CoQ10 effects the statin is producing. Magnesium depletion is independently associated with muscle cramps and fatigue. In many patients on both medications, addressing the electrolyte depletion alongside the CoQ10 supplementation is necessary to see the full benefit. An RBC magnesium test, not serum magnesium, which is often falsely normal, gives you the accurate picture of intracellular magnesium status. Requested by name if you are on a diuretic. Important: read before acting. Do not stop your statin based on this video. I want to say that clearly and without qualification. The cardiovascular protection that statins provide in patients with established heart disease or significant risk factors is real and documented. The muscle effects I have described are a management problem, not a reason to discontinue a medication that may be protecting your life. What changes after this video is not your medication, it is the monitoring alongside it and the conversation about supplementation that should already be part of your care. Write this down, or replay this section. These are the exact words, your exact words at your next appointment. I've been on statin name and dose for X years, and I've been experiencing fatigue/leg cramps/reduced exercise tolerance. I'd like to investigate whether CoQ10 depletion could be contributing. Can we run a creatine kinase level and, if available, a CoQ10 blood level at my next draw? If you want to discuss supplementation, I'd like to discuss adding ubiquinol CoQ10 alongside my statin. Can you advise on an appropriate starting dose for my specific situation, and are there any interactions with my other medications I should be aware of? If you are on a diuretic alongside the statin, I'm also on diuretic name. I understand diuretics can deplete magnesium and potassium. Can we run an RBC magnesium, not serum magnesium, to check whether electrolyte depletion is contributing to my muscle symptoms alongside the statin? If your cardiologist says CoQ10 depletion from statins is not significant, I understand it may not be universally symptomatic, but given that I am experiencing symptoms that are consistent with depletion and that a trial of ubiquinol carries minimal risk, would you be comfortable with a 12-week supervised trial so we can assess whether my symptoms respond? Let me bring this back to Bernard. We measured his CoQ10 level. It came back at the low end of the reference range, not dramatically below, but at a point where the research suggests meaningful functional compromise in patients with muscle symptoms. His CK was mildly elevated, not in the range that triggers alarm in a routine panel, but elevated relative to what a pre-statin baseline would have shown if one had been taken. His cardiologist, to his credit, was open to the conversation. He did not dismiss the data. He agreed to a trial of 200 milligrams of ubiquinol daily, taken with dinner. At 8 weeks, Bernard came back. He had walked 3 miles that morning, his full original route, for the first time in over a year. His nocturnal leg cramps had stopped. The tiredness that had been sitting at his baseline had lifted enough that he noticed its absence. He told me, "I thought I was just getting older. I told myself I was just getting older, and I was. but I was also getting something I could have fixed and nobody thought to check. That is what this channel is for, not to frighten you about your medications, not to turn you against your doctors, but to make sure that every medication you take is being managed with the full picture, not just the benefit it provides, but the monitoring that makes the benefit sustainable. You deserve that full picture, and now you have part of it that was missing. Before you go, I have one question for you. How long have you been on your statin? And has anyone ever checked your COQ10 or your CK level since you started it? Put it in the comments, just the duration and whether the test was ever done, because I think the answer for most of you is going to tell its own story. And when you share yours, you give someone watching this who has been tired for 3 years and has never thought to ask this question the reason to finally ask it. Subscribe if you want to keep having these conversations. Free. First link below. When you write to me, I write back.